Hello everyone, welcome to our Zoom meeting. Today we're gonna talk about three different topics. Hello everyone, welcome. And we're gonna start with Dr. Malaz, and I'm gonna show the screen with the agenda. So this will be covered the hypertension whiteboard and the reason why many research papers are getting rejected. We're going to start with this topic first. So when you're ready, Dr. Malaz, please take it from here.
Okay, I will share screen.
السلام عليكم.
عليكم السلام ورحمة
وعليكم
الله.
السلام.
Yeah, this is
Dr.
Hajer
Hajer.
Ali. Yeah,
Dr. Hajer.
I'm good. How are you?
Very good, thanks.
Yeah, I will start the meeting. Sorry for the delay.
That's fine. So Malaz, let Dr. Hajer start and then
Okay.
we'll talk.
Okay.
Thank you. Dr. Hajer, when you're ready.
Okay. Let me share my screen. Are you able to see my screen?
Yes.
Okay. Okay, so I will start with an important topic about hypertension in older patients. From this presentation, you will gonna know how hypertension different in older adult in terms of diagnosis and pathophysiology and how different in older adult. And also we are gonna speak about the treatment, including the non-pharmacological treatment and pharmacological treatment, including selection of antihypertensive agent and adjusting the medication for older patient. The topics that will be covered, epidemiology, physiology, clinical evaluation, treatment, including lifestyle modification, as I said, pharmacological therapy, and follow-up visits. There is a special consideration in hypertensive emergencies and urgencies, and also the hypertension in long-term care setting, like in nursing home and in frail older adults, the renal artery stenosis. So the epidemiology, systolic blood pressure increase progressively with age. Diastolic blood pressure plateaus in the 5th to 6th decade. 65% of non-institutionalized American more than 60 years old have hypertension, and 50% of older adults have their hypertension controlled, 50% of them. There is increased systolic blood pressure. The increased systolic pressure is associated with cardiovascular, cerebrovascular, and renal disease. It may also increase the risk of age-related cognitive decline and cognitive disorders. There is some barriers that lead to increased systolic blood pressure in older patients. Many factors can contribute, for example, to the poor rate of control. For example, the lack of awareness of hypertension and misinformation on desired normal blood pressure goals, all these issues appear to be particularly a barrier among all older Black and Hispanic women. Other factors that related to disparities from providers, like in practice, the concept about hypertension in older adults also contribute to this age-related disparities in control rate. Physiological change with age. What happens as the people get older? There is a vascular stiffening, which increase the peripheral vascular resistance and decrease the vascular compliance, decrease sensitivity of the baroreceptor reflex, increase the blood, decreasing the blood pressure. Sympathetic overdrive, this lead to widespread vasoconstriction and impair the vasodilator systems. There is salt sensitivity shift. The kidney function and system involved in sodium balance lead to increase in salt sensitivity. Okay, also, there is dysregulation, not only increased blood pressure, there is dysregulation of blood pressure, and this leads to perfusion risks. Because the body, aging impairs the body's ability to stabilize the blood pressure. This is why older patients prone to drop in blood pressure due to eating, like postprandial hypotension, or when they standing, or systolic hypotension. Also, the medications they take affect this issue. Diagnosis of hypertension. Due to blood pressure variability, diagnosis requires at least 3 blood pressure readings taken on 2 separate visits. Okay, 3 blood pressure readings taken in 2 separate visits. So in case of if the patient have extreme blood pressure variability or White-coat hypertension, resistant hypertension, in this case, we will gonna put ambulatory blood pressure monitoring. Okay, avoid 𝗿𝗲𝘀𝗀𝗿𝗀 gap by inflating the blood pressure cuff more than or 40 mmHg higher than the pressure required. Clinical evaluation. Exclude secondary form of hypertension. Identify if there is complication and organ damage, like retinopathy or renal impairment, nephropathy. Determine the cardiovascular risk factors and identify comorbidities. Inquire about lifestyle, smoking history, dietary intake of sodium, fat, alcohol, and also about physical activity of the patient. What are the benefits of treatment of hypertension? Treatment reduces the overall mortality, the cardiovascular risk events, heart failure, and stroke. Evidence not as consistent in those more than 80 years old. Okay. The hypertension in the very elderly trial study also showed decreased mortality in those older than 80, but did not include frail or very old individuals. Okay. Okay, treatment targets. Always focus on the systolic blood pressure and pulse pressure. In general, systolic blood pressure should be between 135 to 140, diastolic less than 90. Diabetic patient has a special consideration. We have to put them on tight glycemic control, systolic blood pressure less than 130 over 85. Systolic blood pressure is a stronger predictor of adverse outcome than diastolic in older hypertensive patients. Lifestyle modification, it is adjunct to drug therapy in all hypertensive patients. Also, we can start with it. It's for weight reduction, exercise, stress reduction, sodium reduction, increase intake of potassium in form of fruits and vegetables. We have DASH diet also. Wait. A treatment recommendation for hypertension begin with non-pharmacological approach, as we said. Based drug selection or combination therapy on individual patient characteristic. It depends on the patient characteristic. We start with low dose thiazide diuretics. We use also long-acting calcium channel blockers, ACE inhibitors, angiotensin blockers. As the first choice for initial pharmacological therapy, as we will gonna see later in details. When you start drug therapy, begin at half the usual dose. Increase the dose slowly and continue non-pharmacological therapy. Okay, lifestyle modifications. Treatment goal should be judged by systolic blood pressure and based on the patient comorbidity profile. Yeah, it is individualized per every adult because they have many times they have multiple comorbidities. Avoid excessive reduction in blood pressure, in diastolic blood pressure, less than 60 to 65. Okay. Okay, pharmacological treatment. We start with diuretics. Significant benefit in mortality, stroke, and cardiovascular events with low-dose thiazide type diuretics. Adverse event profile of thiazide are hypokalemia, hyperuricemia, hypomagnesemia, hyponatremia, and possible glucose intolerance, hyperglycemia. More likely with higher doses. Yeah. So we will start with lower dose. Potassium replacement is important with thiazide to prevent arrhythmia, minimize glucose intolerance. Loop diuretics usually reversed for patients with congestive heart failure or chronic kidney disease. Aldosterone antagonist helpful in hypokalemia. Okay. So we will start diuretics. The preferred one is thiazide diuretics. In case of congestive heart failure or chronic kidney disease, loop diuretics is the preferred one. Okay. ACE inhibitors can be used as initial monotherapy for hypertension in older patients. The adverse event, cough, hyperkalemia, angioedema, renal insufficiency, and especially renal insufficiency, especially in renal artery stenosis. There is rare neutropenia and agranulocytosis. This is very rare. Okay, ACE inhibitor particularly advantageous to patients with diabetes and those with heart failure. Angiotensin receptor blockers. This block the effect of angiotensin 2 on type 1, on the type 1 angiotensin receptor, used as a first-line therapy or as an alternative to ACE inhibitor, especially in those with diabetes, heart failure, and microalbuminuria. It is an option for patients who cannot tolerate ACE inhibitor if they develop side effects like cough or hyperkalemia. Renin inhibitors. As effective as ACE inhibitor or ARBs, in blood pressure lowering effect, long-term data are still not robust for older adults. No dose-related increase in adverse events in older adults, significantly more expensive, associated with diarrhea, no data on safety in those with GFR less than 30 milli per minute. So it is expensive. If ACE inhibitor and ARBs available, will be fair. Oh, sorry. Would be first. Calcium channel blockers used at low dose. Pharmacokinetic change with advancing age. Do not use short-acting calcium channel to treat hypertension. We use long-acting calcium channel blocker. Adverse events, ankle edema, headache, postural hypotension, and constipation. Beta blockers, not recommended for first-line therapy, monotherapy. Usually we use it, provide no reduction in all-cause mortality or myocardial infarction and only modest reduction in stroke. Beta blocker is used in those with coronary artery disease, those with a history of myocardial infarction, and certain patients with heart failure. Otherwise, we do not use beta blocker as first line. There is other classes, alpha agonist or alpha receptor antagonist, alpha 1 antagonist are not appropriate first line therapy for hypertension because it precipitates postural hypotension. Alpha receptor antagonist therapy might be considered as part of multi-drug regimen, especially in those with potassium. Especially with those with prostatitis, because these drugs have been shown to be efficacious in improving obstructive urinary symptoms. So alpha blockers preferred with those with obstructive urinary symptoms. Direct vasodilator like hydralazine and minoxidil are considered last-line therapy due to tachycardia, arrhythmia, and fluid retention. Centrally acting agents like clonidine are poorly tolerated and associated with sedation, bradycardia, and reflex hypertension. Tachycardia if abruptly stopped. Alpha beta blockers like labetalol used in hypertensive urgency and carvedilol in heart failure with reduced ejection fraction. Both may be associated with weakness and orthostatic hypotension. Okay, so here it depends on the comorbidity, the use of alpha blocker or direct vasodilator, central agents like clonidine or alpha beta blockers, which you use in emergency. Okay, that now what about the follow-up visits? What is a what is assess in the what we do in the follow-up visits? We assess the adherence to therapy. We monitor the adverse effect, especially postural hypotension, measure the supine and standing blood pressure, supine and standing, and also encourage blood pressure monitoring outside the clinic. Use interdisciplinary team approach if available. Adjust dosage of medication cautiously. Reinforce lifestyle medication. Evaluate for refractory hypertension. How frequent is the follow-up? Attempt to reduce blood pressure target level too rapidly are unnecessary and likely deteriorate. Yeah, so always reduce the blood pressure slowly. In general, for follow-up, we allow 4 to 6 weeks between visits. It may take up to 10 to 12 weeks for full pharmacodynamic effect after starting the medication or increasing the dose. So we have to wait like 12 weeks to see the effect of the medication. The follow-up between 1 month to 1.5 months. Adjusting the therapy. When blood pressure has not been successfully reduced to target level, consider cautiously increasing the dose slowly. Adding another medication. In particular, a thiazide type diuretic. Or switching to another class of medication. All of this to adjust the blood pressure. If blood pressure target not attained on 3 drug regimen, Evaluate patient for refractory hypertension. Consider stepping down treatment when the patient has maintained target blood pressure for more than 1 year. We will stop the medication for hypertension. Okay, let us talk about hypertension emergency and urgency. What is hypertension emergency? It is vascular compromise of vital organs due to extreme blood pressure elevation, hypertensive. For example, it will lead to hypertensive encephalopathy or pulmonary edema, aortic dissection, unstable angina. Management of hypertension emergency in acute hospital with continuous blood pressure monitoring. Parental administration of antihypertensive. As we said, we use like labetalol for that. Do not initially target a normal blood pressure level. When we have to step down slowly. Try to achieve 160/110 gradually over the first 6 hours. 160/100. Do not lower blood pressure more than 25% within the first 2 hours. Yeah. Okay, let us see hypertension in long-term care setting. Hypertension affects about 33 to 66% of residents of long-term care facilities. There is postprandial hypertension affect about 33% of the residents. An independent risk factor for fall, which postprandial hypertension, independent risk factor for fall, syncope, stroke, and mortality. How to manage patient in long-term care facilities. Risk-benefit ratio of treatment is unclear in this population. Patient of advanced age, patient with multiple comorbidities. We don't know the risk-benefit ratio. Some evidence suggests that avoiding aggressive blood pressure control, avoiding blood pressure less than 130 is likely safer on those population. Several studies have identified antihypertensives, particularly vasodilator, as a fall risk factor in this population. Okay, another special consideration is renal artery stenosis. It presents in 7% of older adults. 25% of those with creatinine more than 2 mg/dL. We diagnose it with Doppler ultrasound or CT-MRA angiography. Medical therapy, lifestyle change, and blood pressure medications. Percutaneous renal artery revascularization and stenting are options. But clinical benefit for stenting is limited in older patients. Okay, don't screen for renal artery stenosis in patients without resistant hypertension and with normal renal function, even if non-atherosclerosis is present. In a summary, treatment of hypertension reduces the risk of cardiovascular disease event and mortality in older adults. Lifestyle modification is recommended. First-line drug therapy can include any antihypertensive class except beta blocker in non-cardiac patient, of course, or alpha blockers. So you can start with any medication, but not beta blocker or alpha blocker. Beta blocker in cardiac patient is okay. Start low dose and go slow. Monitor for false postural hypotension and other adverse event. Yeah. Okay, this is the end of the presentation. I have some cases we're gonna ask so far if anyone have question. If no, I will proceed. This case 1 is a 78-year-old man is seen for follow-up related to high blood pressure. He has occasional headache and stable 2-block 200-meter claudication. He stopped smoking 15 years ago. So he's old man with high blood pressure, came for follow-up. He has occasional headache and claudication. He stopped smoking. Okay, history. He has a history of hypertension, diabetes, and peripheral artery disease. Medication, lisinopril, hydrochlorothiazide, amlodipine, aspirin. The diabetes is controlled with diet. Okay. Examination. Blood pressure is 165/90 sitting and 149/78 standing. Heart rate is 70 and regular. There is no carotid bruit and chest is clear. Systolic bruit is heard in the left hypogastric area. S4, there is S4, no murmur, no edema, peripheral pulse present. AKG, voltage suggestive of left ventricular hypertrophy. Ultrasound shows 70% ultrasound of the kidney, renal artery, sorry, shows 70% stenosis of the left main renal artery. The labs creatinine 1.2. Other findings normal. Which of the following is the most appropriate management? Add clonidine, transdermal patch, 0.1 milligram per week, or perform percutaneous stenting of the left renal artery, which is 70% stenosis, or replace hydrochlorothiazide with chlorothalidone, 25 milligram, or add doxazosin alpha blocker, 2 milligram per day. Any answers?
Replace the close
Sorry?
design. I think we can first like increase the dose for hydrochlorothiazide, 25 milligram.
Increase the dose
Yeah,
or replace it?
I mean replace
Yeah.
the hydrochlorothiazide with
Mm-hmm.
25 milligram.
Yeah, replace the hydrochlorothiazide. Yeah, because this patient have he have orthostatic hypotension. I guess. No.
Could you please
Go ahead.
return to the page of the hypertension? I didn't notice that he has orthostatic hypertension.
Okay. Yes, we choose chlorothalidone because it is more effective. Because I mean, the patient have high blood pressure, have 156/90. It is still high with 3 medication. So we will give him chlorothalidone. I think it is more efficacious than hydrochlorothiazide. Okay. That is why we use this medication.
Also, yeah. Also, hydrochlorothiazide, I think it is cause hyperglycemia, and he is already diabetic. So, because thiazide cause hyperglycemia, it's also benefit his diabetes also to change the medication.
I think it is the same brand. I mean the same. Both of them are thiazide diuretics.
Yes, both of them.
Yeah. Yeah, but the efficacy of this medication.
Blood pressure, like he has orthostatic hypo, and I think chlorthalidone is more better in this situation because it can decrease the sodium flow in the urine. So I think he can make balance in the electrolytes or chlorthalidone.
I think it is an issue of the efficacy only. I'm sure. But otherwise, the side effects would be the same. Okay. Okay, case 2, 78-year-old woman comes to the office for follow-up. She has a small lacunar cerebral infarction 1 year ago. She has never smoked. She has lacunar cerebral infarction 1 year ago. She has history of hypertension only. Medication aspirin, hydrochlorothiazide, 12.5, lisinopril 40 milligram. She is in 2 medication, antihypertensive, and had history of cerebral. Blood pressure is 150/80. Heart rate is 82. Lungs clear. Heart normal. No vascular issues. Which of the following is the most appropriate systolic blood pressure goal for this patient? 150/159, 140/149, 130/139, or less than 130.
Okay. 150.
Sorry, you said 150?
Just we didn't want to make her blood pressure like go down because she has lacunar infarction before, so we can keep the pressure still a little bit high, so we can keep it in 150 to 159.
I think 150/159 is a little high.
Yeah,
Yeah.
maybe, yeah.
I think less than 30, 130.
Less than 130?
Yeah.
No.
No. Close. It is
So
one.
this is 130 to 130.
Yes,
Indeed.
yes. Yeah. Yeah, this is optimal for this patient because of the of the lacunar infarction. Yeah. We put for lacunar infarction, the target between 130 to 139.
Okay.
Yeah. If there were no previous stroke, lower blood pressure goal would be justified, like normal, less than 130. For the previous one, we put we replaced the hydrothiazide because the thiazide is long acting. That is why it is more effective.
Yeah, and also I searched it up right now, and also they mentioned that the efficacy is doubled for 𝗿𝗲𝘀. Yeah, the efficacy is doubled also.
Okay, thank you.
Yes, sure.
Okay, let us go to the last case. An 88-year-old woman is seen for 6 months follow-up. She resides in an assisted living facility and is independent in all activity of daily living and instrumental activity of daily living. She is occasionally dizzy on standing, but she has never fainted. History of hypertension, myocardial infarction 10 years ago. Medication hydrochlorothiazide, lisinopril and aspirin. Examination, blood pressure is 160/70 on sitting and 135/60 on standing. Soft carotid bruit is heard on the left. Soft grade 2 murmur, systolic murmur on the left side of the chest. EKG, there is left ventricular enlargement. Creatinine 1.2, sodium normal, potassium normal, calcium normal. So she has hypertension, MI, history, and soft carotid bruit. Left ventricular enlargement. Which of the following is the most appropriate recommendation? Replace hydrochlorothiazide with amlodipine. Replace hydrochlorothiazide with 𝗿𝗲𝗀𝗃. Replace lisinopril with losartan, lisinopril with metoprolol.
ACE inhibitor, replace it with ACE inhibitor, or losartan. No, it is the same. Sorry.
Right, hydrochlorothiazide with amlodipine.
With amlodipine. Yeah. Why?
Because amlodipine is a calcium channel blocker, so it works also as vasodilator, right? So
Yes.
I think also
The
it's
idea-
related to ACE inhibitor and ARB is preferred in patient with any kidney issue.
The patient, if you notice here, the patient has orthostatic hypotension.
Yes.
It's 160 sitting and 135 standing.
Right.
So yeah, whenever the patient have orthostatic hypotension, look for the diuretics. Here she is on hydrochlorothiazide. We can replace it with calcium channel blocker. Amlodipine is less likely to contribute to orthostatic hypotension. So it is safe for this patient. Okay.
Yes, thank you.
Yeah, you're welcome. Yeah, this is the end of my presentation. I guess if anyone have question, I'll be happy to answer.
Actually, I have a question, but you don't have the answer. But if anyone has the answer, can share it with us. For residency purpose, especially for geriatric patient, if there is any resource that cover the main topic, the common chronic disease like diabetes, hypertension, and everything, like a guideline book. So please share it with us.
I have no idea actually, but might I think there is some websites for, but I don't remember actually the exact name. I can see. I can ask and refer back to you in the group.
Okay, thank you. Yeah, I remember the UpToDate website. They mentioned that a lot. Yeah, looking also for book. But thank you so much.
Yeah, but UpToDate need to be in an institution or something.
Yes, this is the problem. That's why I'm seeking book.
No, there is some book. I will. Can you give me your name because I can't.
Sana.
Or I can send it in the general group so everyone can benefit from it.
Yes, thank you.
You're welcome. Thank you. Okay.
Thank you so much. Dr. Hajer for great presentation. Thank you all. And if there is no more questions, we can move on to the next topic.
Yeah, next topic, Dr. Malaz. Or Dr. Lujane, if you are here.
Hello.
Hello. Yes.
Go ahead,
Hello,
Dr. Malaz.
Okay, go ahead. Yeah, Dr. Malaz is going to present the reason why research papers get rejected.
Is it clear? I'm sharing my screen. Is it clear?
Yes.
Yeah, yes, we can.
Okay, hello everyone. I'm Dr. Malaz Salah. Firstly, thank you so much, Dr. Nader, for raising such an important topic and for giving me the opportunity to speak about an issue that silently shapes the fate of our research as clinicians and researchers. Every one of us here knows how to design a study. We know how to frame a research question, how to choose the right methodology, and how to analyze data. We spend months, sometimes years, producing evidence we believe in. And yet a large number of these studies never reach publication, not because the science is weak, not because the data lacks depth, and not because the research question is irrelevant. They are rejected because the writing fails to communicate value quickly and clearly. In today's publishing environment, clarity is not optional, it is the currency. Editors and reviewers are under extreme time pressure. They do not have the space to interpret, translate, or search for meaning. If the contribution of paper is not immediately obvious, from the title, from the abstract, from the opening lines, the paper often ends before peer review truly begins. And this is the uncomfortable truth. In academic publishing, writing is not a secondary skill. It's a gatekeeper of science. That is why today's title is very intentional. The real reason many research papers get rejected, because most rejections are not about fluid methodology, they are about unclear messaging. Today, we will walk through the structure of a research paper, from the title to the references, and examine how each section has a specific job, and how failing to respect that structure is one of most preventable reasons why strong research never gets published. So, if writing is the gatekeeper of science, then it naturally leads us to the next question. Why does this matter so much? And it matters because rejection is rarely a slow or thoughtful process. In reality, most strong papers are rejected early, sometimes within days and sometimes even within hours. At that stage, the science is not examined in depth. And instead, what is being evaluated first is clarity. Editors are scanning, not studying. They are asking very quickly, can I understand the message immediately? Is the structure clear? Is the contribution obvious? If the answer to any of these is no, the paper usually does not move forward. This is where many well-designed studies failed. A paper can be methodologically rigorous, clinically relevant, and supported by strong data, yet it may still be rejected because its value is not visible fast enough. That is a critical problem because research only creates impact when it's read, and evidence only changes practice when it's understood. When clarity is missing, the science does not get a second chance. What makes this even more important is the most of these early rejections are actually preventable. They are not failures of statistics, they are not failures of methodology, they are not failures of communication. And that is exactly why this slide matters. So if writing is the first filter in publishing, then the very first place where clarity is tested is the title. Before anyone reads your abstract, before they look at your methods or results, the title decides whether your paper even gets opened. That is exactly why we start here. Title, let's begin with the main function of a research title. A title has a one core responsibility: to tell the editor and the reader immediately what the paper is about and what it focused on. At the editor level, the title is not read carefully, it is scanned. So the title must instantly communicate the topic, the scope, and the direction of the study. If the title fails to do that, the paper enters the review process already weakened before the abstract is even considered. Now, once the function of the title is clear, the next question naturally follows. How should a title be written to perform that function effectively? This is where preferred style becomes essential. The preferred style for research titles is specific, concise, and direct. Most effective titles fall between 7 and 12 words, not because of aesthetics, but because this length forces focus. Short titles require the author to decide what is the single most important message of this study. In terms of language, we prefer clear scientific terms over abstract wording, simple sentence structure over complex grammar, ambitious over creativity. At the level, clarity always outperforms creativity. And it's important to apply a set of practical principles that consistently strengthen titles. These are the rules of thumb. Let's slow down and look more carefully at the rules of thumb for titles, because this is where many strong papers quietly lost power. These rules may look simple, but each one directly affects how editors interpret confidence and clarity. Let's take them one by one. First, avoid complex grammar. A title is not the place for long, layered sentence structures. When grammar becomes complex, the reader has to pause, and pausing at the title level is dangerous. Editors are not trying to decode meaning, they are deciding quickly whether the paper is worth their time. Simple grammar keeps the message moving forward. Second, make this title catchy but not clever. Catchy does not mean creative or vague. It means immediately understandable. A good title should click the moment it's read. If the reader needs to reread the title, clarity is already lost. Third, avoid redundancy. Redundancy happens when the same idea is repeated using different words. For example, pairing terms like analysis and investigation in the same title adds length without adding meaning. Redundancy signals uncertainty as if the author is compensating for lack of the focus. Fourth, avoid vague opening phrases. Phrases like an investigation of, the analysis of, or the effect of delay the message. They tell the reader what you did, but not what you found or why it matters. So strong titles move directly to the core idea. Finally, be decisive. A confident title reflects confident thinking. It does not hedge, it does not apologize. When a title is decisive, it reassures the editor that the manuscript itself will be clear and focused. And that is the deeper reason these rules matter. They are not just a stylistic preference, they are signals of clarity, signals of confidence, and signals that paper is worth reading. So once the title has done its job, once the paper has been opened, the next decision happens immediately. Does the paper deserve to be read in full? And that decision is almost always made at the level of the abstract. If the abstract fails, the rest of paper rarely gets a chance. So Firstly, let us remind the main functions of the abstract. The abstract has one critical responsibility: to summarize the entire study, not the topic. It must tell the reader in a very compact form why the study was done, what was done, what was found, and what those findings mean. For editors and reviewers, the abstract is not an introduction. It's a decision-making tool. If abstract is unclear, incomplete, or vague, the paper often stops there. So, it summarizes the entire study. How should an abstract be written to avoid the effect, to achieve the effectively? The preferred style of an abstract is clear, structured, and concise. Every sentence must be earn its place. The language should be direct, free of unnecessary background, and focused on results rather than promises. Abstract should move logically from rationale to methods to results to conclusions without storytelling or suspense. This is not the place to set the sense. This is the place to deliver information at the abstract level. Precision matters more than elegance. And once the function is clear and the style is appropriate, we apply a set of rules that consistently strengthen the abstract. Now, let us look more closely at the rules of thumb for abstracts, because these sections alone can determine whether a paper moves forward. First, summarize the entire study, not the topic. An abstract should never read like a general overview. It should reflect this specific study and this specific contribution. Second, clearly state why the study was done. The research question or objective should be obvious within the first few lines. If the purpose is unclear, the rest of abstract loses direction. Third, clearly state that was found. Results are the core of the abstract. This is where many abstracts become weak. Statements like results are discussed or significant findings were observed add on value. Editors expect to see what was found, not a promise that findings exist. Fourth, include key quantitative results whenever possible. Numbers matters, quantitative results signal rigor and allow reviewers to judge importance quickly. Fifth, end with clear conclusions. The abstract should not stop at results. It should explain what those results mean and why they matter. Finally, avoid citations, tables, and figures. The abstract must stand alone. It should be understandable without external references or visuals. And this is the key point. If the abstract does not clearly communicate value, the paper is rarely read further. And at this stage, clarity is not helpful, it is decisive. So, once the abstract convinced the editor that the study is worth reading, the reader finally enters the paper itself, and this is where expectation rises. The introduction now has one job: to justify why this study needed to exist. Let us first remind the main function of the introduction. The introduction is not a summary, and it is not a literature review. Its primary purpose is to explain clearly and logically why this study was necessary. It should place the research within its clinical or scientific context, define what is already known, and identify what is still missing. By the end of the introduction, the reader should understand the problem, recognize the gap, and see why this study is worth their attention. So, to justify the study, the way it's written becomes just as important as what it contains. And the preferred style of an introduction is focused, structured, and purposeful. The writing should move from broad context to specific problem, not in circles, but in a straight logical line. Each paragraph should build on previous one, guiding the reader naturally towards the research objective. This is not place for exhaustive literature reviews or long historical overviews. At this stage, relevance matters more than volume. So, we have to apply a set of rules that keeps introduction sharp and effective. And these rules are First, introduce the topic clearly. The opening lines should orient the reader immediately. If reader is confused in the first paragraph, regaining attention becomes difficult. Second, define key terminology early. Assumptions create confusion. Clear definitions create alignment. Defining terms early ensures that the reader and the author are speaking the same language. Third, relate the study to existing literature. This shows awareness of the field and positions the study within current knowledge. However, relevance is more important than quantity. Citing everything weakens focus. Fourth, identify the research gap. This is the most critical part of the introduction. The reader must clearly see what is missing in current evidence and why that gap matters. Fifth, state clear objectives. By the end of the introduction, the research question or objective should be explicit. They should be about what the study aims to address. And this is the key point. If the introduction does not clearly justify the study, the rest of paper must work much harder to earn credibility. A strong introduction does not overwhelm, it convinces. So once introduction has convinced the reader that the study is necessary, the next questions become unavoidable. Can this study be trusted? And the answer to these questions lives here in the methodology. This is where credibility is either established or quietly lost. Let's first remind the main function of methodology. Methodology exists to demonstrate that the study was conducted in a rigorous, transparent, and reducible way. Its purpose is not to impress the reader. Its purpose is to allow the reader or another researcher to understand exactly what was done and to be able to repeat it if needed. If the methodology is unclear, every result that follows becomes questionable. So, if the goal of the methodology is trust and reducibility, then the way it's written matters just as much as methods themselves. And the preferred style of a methodology section, it should be clear, precise, and factual. This section should be written in the past tense, using active voice whenever possible. The language should be neutral and objective, free of interpretation or justification. This is not the place to explain why results are important or to discuss implications. Here we focus strictly on what was done, how it was done, and why these choices were made. Clarity here builds confidence. And we rely on a set of practical principles to keep the methodology strong and credible. And because these sections often determine how serious the study is taken, firstly, provide enough detail for reproducibility. Every decision that could affect the results must be clearly described. If a reader cannot replicate a study, the methodology has failed. Second, clearly explain who, what, when, where, how, and why. Who was included, what was measured, when and where was the study conducted, how were data collected and analyzed, and why were these specific methods chosen. Each of these questions must be answered directly. Third, mention all decisions that affect results. Exclusion criteria, thresholds, adjustments, and analytical choices should never be hidden. Transparency signals integrity. Fourth, avoid re-explaining standard techniques. Well-established methods do not need tutorials. They need proper citation. Over-explaining distracts from what is truly important. Finally, keep interpretation out of the methodology. Results belong in the results sections, meaning belongs in the discussion. Mixing them weakens both. And this is the key message. A strong methodology does not be sold emotionally. It combines logically. It tells the reader this study was done carefully, transparently, and correctly. So once methodology has established trust, the reader is ready for one thing, evidence. This is where the study is tested, not by interpretation, not by opinion, but by results. Let's start with the main function of the results. The results section exists to present what was found clearly, accurately, and without interpretation. This is where data speaks. The goal is not explain meaning and not to be sold the reader. The goal is to show the evidence in its most transparent form. If the results are unclear, even the strongest methodology loses its impact. So to present evidence, the way results are written must protect that evidence, not distort it. And the preferred style of the results section is objective, structured, and restrained. The writing should be factual and precise, with minimal narrative. Results should follow the same order as methodology and objectives, so the reader can easily connect what was done with what was found. Numbers matter here. Specific values, proportions, and measures are far more powerful than general statements. And this stage, naturality builds credibility. So we have to apply a set of principles that keeps results strong and interpretable. These are the rules of the sum. First, focus on primary findings. The results section is not a data dump. It should highlight findings that directly answer the research question. Secondary or exploratory results should not overshadow the main message. Second, use tables, figures, and graphs strategically. Visuals should clarify, not repeat the text. They allow the reader to grasp patterns quickly without searching through paragraphs. Every table or figure should have a clear purpose. Third, present quantified outcomes. Statements without numbers are rarely convincing. Quantifications allow reviewers to judge magnitude, relevance, and significance on their own. Fourth, highlight the most significant results. Not all results carry equal weight. The results sections should guide the reader towards what truly matters without exaggeration or interpretation. Finally, separate results from discussion. This separation is critical. Where interpretations enter the results section, objectivity is compromised. Meaning belongs in the discussions, evidence belongs here. And this is the key point. A strong results section does not tell a story. It presents facts, and clear facts are what allow meaningful discussion to follow. So once the result has been presented clearly, the reader now asks the most important question of all. So what? What do these findings mean? Why do they matter? And how do they move the field forward? That conversation begins here in the discussions and conclusion. Let's start with the main function of discussion and conclusion. This section exists to interpret the results and place them into clinical and scientific context. Here we move from data to meaning. The discussions explain how the findings answer the research question, how they compare with existing literature, and what they add to current knowledge. The conclusion then distills this interpretation into clear, focused take-home message. If the discussions lacks clarity, the value of the result is lost. So, if our goal here is to translate evidence into the meaning, then the way this section is written becomes especially important. And the preferred style of the discussions and conclusion is analytical, balanced, and disciplined. This is not the balance for emotional language or exaggerated claims. Interpretation should be logical, grounded in the data, and supported by existing evidence. A strong discussion acknowledges uncertainty, recognizes limitations, and avoids overgeneralizations. Confidence here comes from reasoning, not from bold language. And we apply a set of rules that keep this section credible and impactful. First, answer the research questions directly. The discussion should clearly respond to objectives stated in the introduction. If the reader finishes this section is still unsure of the answers, the discussion has failed. Second, interpret results, do not repeat them. Restating numbers adds no value here. The focus should be on meaning, not duplication. Third, compare findings with previous studies. This places the results within the broader literature and shows how the study confirms, extends, or challenges in existing evidence. Fourth, explain unexpected findings. Unexpected results should be addressed openly, not ignored. Thoughtful explanation strengthens credibility far more than selective reporting. Fifth, discuss implications and future direction. This is where clinical relevance and research impact appear. What do these findings suggest for practice? What questions remain unanswered? And what should come next? Finally, keep the conclusion focused and concise. A strong conclusion, do not summarize the entire paper again. It reinforces the main message and leaves the reader with a clear understanding of the study's contribution. And this is the key point. The discussion and conclusion are where evidence becomes insights. If this section is weak, even strong results lose their influence. So after the discussion has interpreted the findings and clarified their meaning, the paper reaches its final checkpoint of credibility. This is where many authors relax and where many papers quietly lost trust. We are now at references. Let's start with the main function of references section. Reference exists to demonstrate that the study is grounded in existing evidence and positioned correctly within scientific literature. They show the reader and the editor that the authors understand the field, respects prior work, and build on reliable sources. References are not decorative, they are a statement of scientific integrity. So, references represent credibility, then how they are selected and presented matters just as much as how many are included. And the preferred style for references is accurate, consistent, and disciplined. Editors expect strict adherence to the journal's formatting guidelines. Consistency in citation style signals attention to details. Accuracy signals respect for the literature. At this stage, even small errors, misspelled authors' names, incorrect years, or inconsistent formatting can raise doubts about rigor of the entire manuscript. And that means we have to apply a few essential rules that keep referencing strong and credible, and these are the rules of the thumb. First, follow the journal's formatting strictly. Reference style is not optional, it's a requirement, and failure to comply signals carelessness, even if the science itself is strong. Second, prioritize primary source whenever possible. Primary studies carries more weight than secondary summaries or opinions. They show direct engagement with the original evidence. Third, ensure accuracy and competencies. Every reference should include all required details, authors, title, journal, year, volume, and page. Inaccurate references and undermine trust. Fourth, ensure consistency across the entire list. Inconsistent formatting suggests that references were added without careful review. Consistency reflects professionalism, and this is the key point. Strong references do not make a paper impressive. They make it reliable. When references are handled carefully, they reinforce the credibility of everything that comes before. So let me end with this. Most research papers do not fail because the science is weak. They fail because the message never becomes clear. When we have seen today that every section of the paper has one clear job. The title opens the door, the abstract earns attention, the introduction justifies the study, the methodology builds trust, the results present evidence, the discussions creates meaning, and the reference confirms credibility. When structure is ignored, even strong science struggles to survive. But when writing is clear, focused, and intentional, good research becomes visible and strong research becomes publishable. Clarity is not a writing style. Clarity is a scientific responsibility. Because science that is not understood cannot influence practice, cannot guide policy, and cannot change lives. So let me leave you with 3 key takeaways. First, many papers are rejected because of writing not science. Second, every section of a paper has one clear purpose. Ignoring that purpose leads directly to rejection. And third, and most importantly, clarity gets published. Not complexity, not clever language, not impressive wording, clarity. So write your research with respect for the reader, with rigor in its structure, and with confidence in its message. Because when science is clear, it does not seek attention, it defines impact. And thank you so much. And I'll be happy to take any question.
Thank you, Dr.
Thank you.
Malaz. Yeah.
Go ahead.
Yeah, thank you, Dr. Malaz, for this great talk, explaining the reason for rejection. Yeah, I think it will be easier now. Yeah, it helped a lot. It become clearer for us. Thank you so much. If
Thank
no
you
question,
so much.
if anyone have question or comment, if no, Dr. Lujane can proceed. Dr. Lujane?
Hello. Can anybody hear me?
Yes.
Oh,
Yeah,
okay.
yeah, we
That's
can
for
hear you.
having technical issues today.
Yeah,
So today I will hopefully make mine short and sweet due to technical issues, but yeah. So today I'll be talking about the whiteboard AI as to how to use it and use it in presentation. So I'll be sharing my screen right now. Okay, is my screen shared? Okay.
Yes.
So we'll start with the image generation, right? So right now our goal is to create a whiteboard-like style, almost narration kind of thing. So we'll do it something like, I'm using Gemini. So right here, I've already written my prompt that I wanted a masterpiece, vibrant colored whiteboard animation, right? So I'm gonna say, right, oh, I want an image explains how to generate AI whiteboard presentations in a clear and amazing way. So I'm gonna try. I had it done under Nano Banana, which is under Gemini. So I asked it to just make me a prompt image. So right now we're gonna be waiting for it. Oof, sorry, my internet's really slow today. No idea why. So right here, it's given me an image that shows exactly that. So what I'm going to do is I'm going to download the image, right? And I'm going to tell me, write me a narration for this. Well, it can be used in any sort of topic, but right now we're going to try to show it in the brief and simple way, which is how to generate AI whiteboard presentations, right? So I've asked it to write me a narration. Hopefully to say, wait, I'm going to have to edit it. A simple narration. Oh, I have to stop it. A simple. I'm just using brief prompts because I'm not entirely sure if my Wi-Fi can do it. So yeah. Okay. All right. So here, okay. Here it's giving me different type of tone, right? It gave me simple, a short and punchy one, a conversational tone. So you can do whatever you want, whatever you feel like you want. And so I'm gonna go here, and then I can go to Google AI, which already have saved up here, right? And I'm gonna ask it to generate. So here, what I'm doing right now is I'm trying to put a narration because it's either A, you can use your voice, or preferably you would want an AI generated, right? Say you want to upload something or explain something brief in YouTube or something or somewhere, but you don't entirely want to use your voice, or you want to create a visual storytelling like thing. So Google Gemini is good for this. As I said, Nano Banana for generation of image, and then you have the Google AI Studio, in which you can find this under the lab. Wait, so right, and here you can choose the voices. You can choose whether you want to do a story like a multi-speaker. You can choose whether to use like the style, whether it's a campfire kind of story, right, or like just use it in really fast. But preferably, I've already set the tone with Gemini, so I'm just gonna use that, right? So yeah, okay. So right now I'm gonna choose a voice, a random one. So I'm gonna use this one. Okay. So right now I'm generating the narration. And while we're at it, we might as well go and check Canva. Yeah. So here we have Canva, in which we're gonna generate the video. You can use CapCut or anything, but preferably Canva, just because of this AI tool, which hopefully is free right now. So right now we're gonna go to apps, right? And then I'm gonna search for an app called Speed Paint, right? Speed Painter. So this app is what generates this style, the narration style of video. Right. So right now I'm downloading it so that it could appear on my files. Wait, sorry, my internet's so slow. Okay, so it's downloaded. All right. So I have apps here. We're gonna go under Speed Painter, and then underneath choose file, right? Hold up. Sorry about that. Yeah, so hold up. We're generating this one. Yeah, so I'm gonna. Oop, apparently it's too high of a. Oh, apparently the file's too large. Okay, I'm gonna have to generate another one. Okay, wait. Generate me. So we're gonna have to generate a simpler picture. So this one as well, you're gonna have to download it so that you can put it under Canva, and then we're gonna have to use it later on. So I downloaded it. Hopefully the file is not that big, so we can put it here. So we're gonna have to. So I'm gonna put it did not download. I apologize for the delay. Well, so you're gonna have to use the same file. Oh my God, the images are too big. All right, wait. Sorry about this. How big is this image? Oh, wait. So we're gonna have to edit this, and instead of 8K resolution, we're just gonna have to say something like something smaller, I guess. So we're gonna say, for example, 2K resolution. So it could be smaller. Or if not, perhaps like I have an image already saved here, but it was on another topic. It was under the topic of the story of my life, but in Zayn Malik's, that was how I was using to practice. So we'll use that image instead because it is not working. So under Speed Painter, no, not this. Yeah, and then choose the file. And then use this. Yeah, so this is another video image that I generated while I was practicing on how to present. So yeah, so you could use hand type, you can use sketch duration over here, you can choose fill in. There's a lot of options to pick on, but then let's simply generate it. Let's add a bit of generation here. Yeah. So then again with the weighting. So I'm going to try to add my audio, which I already saved earlier on. Where was it? Well, it is not working out for me. Okay, we add the design. Okay, so here we have the design that was plugged in earlier on Canva, right? No, from Gemini, and it did not upload the entire video. So we'll have to fill in color. Okay, let's go. So while we're waiting, let's try to add the audio. Well, here it's giving me another thing, but I've already generated under the thing. So I preferably you can add it under CapCut if you saved the video, right? So we have, where did the image go? I'm so sorry, but Canva is not working out with me right now. So you're meant to add it, so you can change the speed. Right. So you can change the speed and then add the voiceover. Unfortunately, Canva is not showing that. I have no clue why, but yeah, so you can change the speed, add a voiceover, and then maybe later on edit it under CapCut. So yeah, I think I'm done because technical issues for today. I'm so sorry. So yeah, thank you so much. If there are any questions and any clarifications, I would love to answer. Thank you. Sorry, it's all working right now.
Thank you, Dr. Lujane. It looks interesting, actually.
Yes, I'm so sorry.
Like,
Technical issues today.
it's
Dr. Hajer.
fine. Yeah, it's fine. Anyone have question?
Thank you so much, Dr. Lujane. Yeah, sometimes you may face some technical issue, but the idea is there. So the steps, if you follow the steps, hopefully it will design and create the presentation for you, the whiteboard, and you can edit it. That's
Oh
good.
yes, sorry. I do have another recommendation as well. It's 𝗿𝗲𝘀𝗀𝗿𝗀. Unfortunately, it's not accepting any of my emails. I think it's a Wi-Fi issue. So yeah, if anyone is also interested in seeing 𝗿𝗲𝘀𝗀𝗿𝗀, it generates the entire thing for you as well, rather than actually editing it under Canva. So yeah, thank you so much.
Thank you.
Dr. Hajer.
Yeah, you're welcome. So there are a lot of other options, and every day there will be new tool. So if you have the idea, then if you use ChatGPT or Gemini, then it will show you some of the updated tools, and you can use any AI. But thank you for showing us this. This is great. Any questions or any comments?
Yes, I have a question.
Go ahead, Dr. Muntasir.
Hello, Dr. Nadir. This is my first day here. I wanted to ask,
Welcome.
do we apply to do one of these presentations, or how does it get done?
Okay, one thing I'd like to welcome you and any new fellows, any of the new fellows, if they are here. Welcome to the program. So the presentation, usually we divide you into some teams, and each team will be assigned a date. Usually we present on Saturdays, so your team will be presenting, let's say, in 3 weeks or so. Then your team leader will arrange who is available that day and what topic you are interested, and then we will have a list of presenters. In case you are available, let's say in next week, and you want to present, then you will look at the agenda and see what topic will be discussed, and you can either present the whole topic by yourself, like today we have 3 presentations and 3 presenters, or you can join someone and divide the presentation between you and the other fellow, or maybe 3 fellows. So in the WhatsApp group, you can ask and see what days you will be available, and you look at the topics and which topic, if you want to present alone or you want to present with someone else. So the team leader for that day will arrange the speakers with each topic. Sometimes the files or the resources might be available in the app. So I'm gonna just show you.
So each day, like a different team will be assigned?
Yeah, so if you go to the app here, first you go to upcoming Zoom meetings, and this will show you next week will be topic 1, dizziness, topic 2, this, topic 3. Sometimes we have 4 topics or so, and sometimes we have resources, so either website or videos, or maybe we have some files. So if you click here, you will have some slides, for example, already made. You can modify this, or you can create your own. It depends on everyone availability and interest, and that's about how we try to arrange by teams. So the pink team will be in 3 weeks, blue team will be next week, something like that. And it's not a fixed thing. Anyone can join any of the groups depending on interest and availability.
Okay.
Thank you.
Thank you. Thank you, Dr. Nadir, for that.
You're welcome. Yeah. Thank you, Muntasir. Any other questions or any other comments, any updates or any ideas about what you are doing, what you are planning to do? So usually we try to work as teams for the presentation, and also we have different teams for project. Let's say if you're interested in doing a certain project, research project like systematic review of something about renal disease, then either you join some teams who are already working a project in that area, or you can create your own team, and then you might be the leader for that team for the research project. And the goal is to know how to start a project from the idea, the topic, the background, the method, results, and final thing. When you want to present that as an abstract, you submit it to a conference, or as a paper, you submit to a journal, or nowadays we are working on developing some mobile application using AIs. So it will help every one of you to work together in certain research area, and I think it will help you when you apply. Thank you. Any questions?
Yes, actually, Dr. Nadir. So I don't know.
Go ahead.
If it wasn't for the thing today, there was another presentation that was meant to be done actually, but I don't think anybody volunteered. But I was really, really excited to hear that one. It was how to stand out on the residency. Like it was an interview, how to stand out on interviews basically. And I wanted to hear how exactly, because I'm not a fellow and I've never done the interview for like matching, but hopefully soon, inshallah. And I'm pretty sure most of the fellows would like to hear how to actually stand up and how to, show up and like how to be the better candidate on or how to present yourself, face value in this interview. So yeah, we would like to hear your advice on that. Thank you.
Sounds good. Thank you so much for raising this important point. So usually we have this topic when it's early in the season for interviews, and we had it a couple of times. Some of the fellows picked or researched about how to do it the done way, how to shine. So we have recorded videos in the past. So if you want to look at some of the previous meetings, we started in 2020. So we have a couple of videos about how to do interviews, how to present yourself, how to answer questions, different types of questions, and so on. So this is one way, is to look back and see what other fellows collected and presented and see if that will help you. The other way, in the video selection or library that we collected from YouTube, we have certain videos that are also helpful. So you can also search the video list that we have in the app about interviews, and some of them will show you some of the other techniques or advice from program directors, for example. So they tell you, we want you to tell us about this, or do this, or don't do this, and so on. This might be helpful. The third option is to one of you or more can work on getting an updated version and present it here. Let's say in March there will be the SOP, and there might be a quick interview for vacant positions. And these interviews, they go fast, so they send you an invitation, and within hours you have to respond, yes, I'm ready. And then they call you, and it might be just a phone call, it might be a video call, it might be only one person, the program director or a couple of faculty members, and they decide very fast on which fellow or which candidate they will accept and so on. So maybe some of you will work on presenting the technique of how to become a good interviewer or candidate during the interviews, if that makes sense. Thank you.
Okay, thank you so much. I will be binge watching that video. Thank you.
Great. Any other questions or any other comments or ideas for? Yeah, go ahead.
Hello, Dr. Nader.
Hello.
My name is Omar. I actually also recently joined your program, and I'm very excited. Today, there were really nice presentations, and I just wanted to ask about the research. If there are any active researches right now for me to join, and how would I be able to join it? Because I want to make the most out of whatever beneficial information I take from the program.
So we have a list of, again, if you go to the app, we have a couple of options, I think, products. So you can search the list of projects. So you can search for certain things. Let's say you are interested in renal disease or brain or dementia, something like that. So we have some list of products that you want to see. If you are interested, you can join some of these, and you can create a project from scratch if you want to start one. Let's say like this, we don't have anybody in this, let's say, project. So you can use this as a starting point. And then we have an abstract where you can look at. It's like a template, it's a draft, and not necessarily the right way for you, but it gives you an idea. You can modify it, and you can pick on it. The other way is to take the same topic, take it to any II, and ask if that topic can be started as a research, and which conference, if you want to make it as an abstract poster for a conference. So this one, for example, can be presented in any telehealth conferences or any internal medicine conferences or family medicine conferences. So if you want to think about it as an abstract, if you want to submit it. The idea of making an abstract, it's fast, and you can do it with a small group of fellows, and you can submit it, and you will get acceptance faster. The other option is to turn this into a paper, and as was mentioned in the topic today, you want to see how you are going to build this, see if it's written similar or something like that. If it's not, it's a good idea. So you want to start by looking at the literature, collecting some of the references, and then build up your method of what you want to do. Is it a systematic review, whatever, and then write the draft. And when you are ready, you can finish the manuscript and submit it to a journal. and hopefully they will accept, or they will give you a review so that you can modify, improve, and resubmit, or maybe they will reject it, but they will tell you maybe you can submit it to a different journal. That's the fast way of doing things. In the past, we did this. The new way of doing it is you want to take an idea and build around it a mobile app. So, for example, if you are interested in, let me ask you, what area you want to apply? Like, are you going to apply to family medicine, psychiatry, neurology, internal, what?
Mostly internal medicine, probably either internal medicine or family medicine.
Okay, so generally, let's say you will be interested in chronic conditions, one of them, let's say diabetes. And so you can ask AI, I want to build an app, mobile application for patients with diabetes or patient with COPD or whatever. Give me some ideas. So it will list, let's say 5 ideas. Pick one of them and say, I want to work on this. So it will either build the code for you, or it will list the steps, and then you ask to elaborate on the steps. If you want to modify things, let's say you want to check the blood sugar 2 times for patients with diabetes and get that in a report, and then be able to print that report or email that report to the primary doctor. So either you can work by yourself on all the steps and you can develop that. It's fast using the AI nowadays. Or if you want to put it in the WhatsApp group, your idea, and then if, let's say, Lujane is interested or Malaz, then you create a small team about that topic or that project, and then you work together. You can divide the task, or you can start and then show them, and then everyone will give you their feedback, and then you improve it, the next version and the third version, and when it's done finally, then you want to test that. If everyone is happy with the product, then we can talk about publishing it, either in a website, or we can even go to Google Play Store or Apple Store. And in the past, we were successful in publishing mobile application in these 2 stores, if that makes sense. Thank you.
Thank you so much, Dr. Nader. That was very beneficial, and inshallah, hopefully I'll be able to do that.
Sounds good.
Yeah, thank you, Dr. Nader, for that. Almar, I'm in your group if you have any ideas for that.
Yeah, absolutely. I will see if there are any ideas that I can suggest that are worthy of looking at.
Yeah, okay.
Sounds good.
Hello everyone, am I coming through? Hi, Dr. Nader.
Hello.
Thank you for this opportunity and thank you for your time. I just want to ask about the making apps thing because I'm not familiar with that. Like, do we need any previous knowledge of programming or stuff like where to start with?
Not necessarily. You, in the past, we want you to go through steps like get the idea, make like writing an abstract or a paper. You want to have a title, for example, and then you want to get some research. Is the title presented or published in the literature? So you don't want to duplicate what's out there. It's the same concept with application. You want to create something that's new or has new features, for example, for the mobile application. So you can search for your idea or your application in Google or Apple stores. If you find some, look at them and see what other features you want to. After you collected all this information, you have an idea, then you can come to Gemini or Canva or ChatGPT, DeepSeek. You can just put a prompt saying that I want to create a mobile application which can be used for people with certain condition, let's say diabetes in this example. I want these features, 1, 2, 3, and I want it to be user-friendly. I want it to be colorful, accessible, or whatever things that you want, and just send it as a prompt, similar to what Lujane was showing us today about creating a picture or something like that. So the app will, or the tool, the AI will create the app for you. So you're going to test that and see if you like it. If you don't, which part you want to modify, then you say, can you change, let's say you don't like the color, make it in blue, you want it in green, then you say, can you change the color theme from blue to green, and it will change the shades. If you want to add more features, you can say add the ability to download a text file or PDF file, something like that. So it will incorporate all these features. And then after you're done, you can ask other fellows to work with you on testing it and giving you feedback. That's what we did in the past, if that makes sense.
Oh, cool. Yeah, thank you.
Thank
It's
you.
much easier now with the AI technology.
It's very, very easy.
Yeah, okay, thank you.
Mm-hmm. You're welcome.
Oh, wait, just another thing to ask. So it has to be focused on geriatric, right? So chronic diseases like that.
Not
Not really.
necessarily.
Okay. Okay.
Anything, the posters or the app or the journals or the articles for journals. We had in the past fellows who went for pediatrics, so they presented their topics in pediatric conferences, some in psychiatry, some in neurology, some in cardiology. So not necessarily, we started with geriatric because I'm a geriatrician, and then we have different fellows with different interests. So it depends on your interest, basically.
Okay. Thank you so much, Doctor.
You're welcome. Thank you. Okay.
I wanted to ask, how do we look for conferences to go to or to present at?
So in the past, we were successful in presenting in different conferences. I'm going to show you some. So if you go to this website, I can share it in the chat. Basically, this is a new website, or just we want to build the combined research. Here you can see what our fellows in the past they were able to present. So this one in cardiology, I think she presented some. We have other fellows who presented in general medicine, disseminated health. And then we have some rheumatology, heart disease, some international, like in Qatar. If you have some fellows there, you can work and then present somewhere there. We have fellows who did pathology, so they presented in pathology. Neonatology in Saudi Arabia, for example, here in renal failure or general medicine also. Here Saudi Arabia as well. Lena kidney here in the US. This is geriatric, and then nephrology, neurology, cardiology. So all these conferences you can look at and see if you are interested in one of them. The other way is to look at what's your interest?
Family medicine.
Let's say you are interested in internal medicine, and it is 5 conferences. So you can list the conferences that for internal medicine that can accept abstract. So here are 5, for example, and it can list you the deadline. So you can work on getting something by April for McMaster International Conference, for example. If you are generally working on general internal medicine, if you are interested in a specific area, cardiology, then you can modify that question to list the cardiology conferences, if that makes sense.
Yeah.
Yeah. Good question. Any other questions? So what we did in the past, let's say, the same, I want to go to McMaster International. So I can say list 5 ideas for some sharing. For So let's say you want to submit to the McMaster, this one. So still we have a few weeks to, like 2 months to apply. So this is one of the ideas, specifically for all the adults. If you are interested, you can do a retrospective chart review, but we want it to be online. So just online and not chart review, because it can list you here chart review, and the problem is you need to access hospitals. This one is kind of a survey based, so you can see if you want to build this one. You can say elaborate on that. This is one also on a survey based. It is survey based, so this is an online study, for example. So if you are interested in number 3, you can say elaborate. So it will show you the steps of doing this, the rationale, the background. So you are going to use LLM or the AI to help with that as well. And then the primary core or objective, and then the secondary goals, what you want to do, and then study design. So you want to reach out for residents of IMGs, fellows, and so on. This is how you do the survey and then the analysis, so on, if that makes sense. So it's doable for any one of you to create a list of possible abstract that can submit it to a conference, and then create an idea that can be done using online resources instead of actual chart review. Sometimes you might have an access to databases that has some data nationally. So you just download the database and then use some tools to analyze certain aspects. That's also a possibility, if that makes sense.
Yeah, it makes sense. Really helpful. Thank you.
You're welcome. Thank you. Any other questions or any other comments or any other suggestions, ideas? If not, I'd like to thank you all for attending this meeting. Thank you all, the presenters from today's. Thank you, Dr. Hajer and your team. And thank you to those who will come and watch the recording in the future. Have a wonderful day. We'll see you next week. If you have questions, please don't hesitate to reach me by email, text, WhatsApp, or you can call. Thank you. Have a good day or good night, wherever you are. Assalamu alaikum.
Thank you, Dr. Nader. Thank you very much.
You're welcome, Dr. Azza. Have a good one.
Thank you, Dr. Nader.
Thank you, Dr. Hajer.